Well, hello everyone out there that I can't see. Uh, I hope you're all enjoying the day so far. I think it's been brilliant so far. Paddy, Joe, Sam, well done for all the organisations gone. It's been a real privilege for us to work alongside PBS UK and NHS England in putting this together, and I think this just brings a really nice close to what's been a fantastic piece of work. So I'm Jonathan Beebee. I am the Chief Enablement Officer and Nurse Consultant for PBS4. I won't go on too much about it, but I started PBS4 myself 6 years ago. It's a not-for-profit social enterprise. Started off with me with no money, just an idea and a laptop, thinking I'm gonna do something that makes a difference. And 6 years later, here we are. And some of you will know my background, but yeah, I left college and started working as a care assistant in a nursing home. Wondered at that age whether it was the right career path for me, so took a leap of faith and went into the porn industry. I was working as a pawnbroker, and during my time as a pawnbroker, I suffered a severe head injury. Nothing to do with being a pawnbroker. It's a very credible industry, but yeah, I had a severe head injury. The doctors first told my parents I was going to die. Then they said their words were I would be a cabbage, meaning that I would be in a wheelchair. I'd be unable to talk. I'd be able to feed myself. I would be totally reliant on others for my help. That got me thinking. Well, what would my life be like if that was my future? And then I found out about learning disability nursing. So trying to be a learning disability nurse, a huge range of experiences. I mean, I think I've worked in every setting going, every side of the table, NHS, private providers, Department of Health, CQC, NHS England. I've worked for them all. And I kind of got a bit bored of looking at services and going, if I was receiving that support, would it be good enough for me? Thinking back to those days when it could have been me receiving the support. And too often it wasn't. And then sort of looking at the sort of expert model that I was being accustomed to at the time of sitting far back in my ivory towers, looking down and tutting at services, thinking if I really want to make a difference, I've got to roll up my sleeves and do it myself. And that's where PBS4 has come from. So we're not-for-profit social care provider. We're working in Hampshire, Dorset, Berkshire and Oxfordshire. We've got one service in North Somerset, and we're keen to expand around the Bristol area and North Somerset area to get some stability around that team we've got there. So I'm sure many of you will recognise the highly academic quote at the top of this page: "To take away our expression is to impoverish our existence." That's Rue Reynolds, Enter Shikari, Radiate. That gives you, that kind of sets the academic benchmark for where my presentation is at. I'm referencing 90s rock. So yes, but I think for me that summarises what PBS is for. People with learning disabilities have a disability in learning. They learn fewer behaviours than what we do. And a natural human response when we're faced with a challenging behaviour is we want to stop that behaviour. And if you've only got a limited number of behaviours in your repertoire, if we're stopping those behaviours, we're taking away people's expression. And therefore impoverishing their existence. So positive behaviour support is about understanding what people are communicating and giving people more ways to communicate. It's not about taking people's expression away from them. So that's the real starting point of where we're from. So I've kind of answered what is PBS4 in my first slide. So no need to listen any further if I've bored you already. I'm sure you won't. So I'm just going to go through some slides now for the rest of it. So now, in Paddy's presentation earlier, he referred to the Pied Piper Hamlet. I've gone for Jack in the Beanstalk, so we've got a bit of a fairy tale theme going here, which is really good. I'm sure that many of you are familiar with the story of Jack and the Beanstalk, where as you can see from the picture here, Jack's mum sends him to market to go and sell their cow. He meets this guy that says, I've got some magic beans I'll give you for that cow. It's gonna, it'll grow really tall. It'll give you access to all the wildest riches. It will give you the future you and your family wants. Jack goes, yeah, great, sure, have my cow, I'll take them beans. And then he goes home to his mum and says, hey, mum, you'll never guess what? I've sold the cow for these magic beans. You can imagine the conversation. What have you done? Are you mad? There's no such thing as magic beans. And there are probably millions of people at the same market selling their own type of magic beans. And how do you know which ones are really the magic beans and which ones aren't? And I think in a lot of ways that represents what's going on with positive behaviour support at the moment. It feels a bit like a magic bean. We're peddling it and we're saying this is going to be a great solution for you all. But we know that some of those magic beans are genuine and have the key elements of what PBS is and bring it all to fruition. For others, they're just beans that have been dressed up nice in magic wrapping and they look really cool. So I just think it's a real challenge for people with learning disabilities, for families and for commissioners to know who is really selling those magic beans. Just think it's worth going over as well what some of the current challenges are in social care at the moment. There's not enough competent providers out there. I saw in the chat that one of our colleagues, Marquez, is here from Hampshire County Council. They did some excellent work there about the least restrictive practice project, where they're looking at empowering providers to have the skills that they need to deliver high quality positive behaviour support. And it is just really frightening that there's not enough competent providers out there, and we keep hearing we need more of a skilled workforce. There's a history of services relying on hospitals when things go wrong. So crises happen. There's not really a lot of option out there often, other than referring the person to a secure hospital to manage with that crisis. And then when a person gets into hospital, there's a lack of trust in what the quality of social care is out there. So you then can't discharge people from out of there. So we've got this sort of historic like revolving door policy that has evolved over time, and we just can't seem to find our way out of it. The Transforming Care programme has been brilliant and it has really helped push things forward. Many of you who've heard me before will know I've really supported the program. I think it's been a great approach, but my biggest criticism of it's been that a lot of the focus has been about closing hospitals. That's not what positive behaviour support's about. If you want to make something redundant, you've got to provide something that's better than that to replace it with. So we need to get competent community services out there.
I know you said you were seeking a bit of engagement and that kind of stuff. I just wanted to, just thought popped in my head. It was really interesting. Like I said, who's peddling the magic beans? And I thought I've never thought about it in that way. It's really interesting because I think a lot of us that know about PBS or working with know how much work is involved in setting that up and doing it properly. And I think it's really interesting. I think sometimes people are being told, do this PBS stuff, it's your magic bean, without perhaps knowing how much that actually involves. So I think that just in itself there was really interesting for me, thinking, yeah, I think that sometimes it's people that perhaps aren't clear because they haven't done it. I'm not judging, but they don't know how much work's involved. So people are hearing this, oh, just do a bit of PBS, it's going to solve all your problems. And people go, oh, great. Yeah. And then the challenges start. So it's a really interesting point.
Yeah, I was really interested in listening to Hamish earlier in his presentation and talking about some of the jargon that's out there and the language that we use. There is this barrier between layperson understanding of PBS and clinical understanding of PBS, and there's a big void in the middle. And social media is great, but we use social media to connect with the professionals and publicly talk about what we're doing, which means we use some of the really complex language. And then people go, oh, you're using that professional language, this isn't for us. And that's not the point. I made a comment in it in Hamish's presentation. We don't get put off when a GP uses terms like ankylosing spondylitis. We're really pleased that GPs know terms like that, because that shows that they've got professional training and they understand what's going on. But we wouldn't expect them to have that bedside manner when they're talking to patients, to use really complex clinical terms. They've got to talk in human language when they're talking to humans. But people deserve professionals to provide their support. Anyway, went off on a tangent then. I think I'll come back to the tangent later on as well. So yes, all those clear definitions of what PBS is. there is interpretation out there of what it is, and sometimes the interpretation takes over from the reality. There's no real censorship or license for who's doing it and what's going on. So there isn't really any kind of governance of what PBS is. And you mentioned earlier, Paddy, you were saying about people having bad experiences of ABA, and we can't disagree with that bad experiences of ABA. We know there's a load of rubbish PBS out there, and if people are saying PBS is rubbish because it affects my son, then they've probably had that rubbish PBS. They may have had that good PBS and it's gone horribly wrong for them as well. But we know that there isn't a good quality out there, and we're not going to win any friends by saying you're wrong, you haven't had bad PBS. They have had bad PBS, they've had bad experiences, and we know it's out there. We've got to keep raising the bar, and that's what we're trying to do with PBS 4. We're trying to show what good looks like. The only way of convincing people it can be done different is to show it can be done different. There's lots of reasons not to trust social care providers. Many people have had their fingers burnt or really bad experiences. There's financial pressures on the system. Lots of areas we work in have frameworks. Those frameworks are often described as a race to be the cheapest. We've had to walk away from some frameworks we were applying to just because we can't afford to provide at the framework rates. They're providing, they're saying like provide support at £16 an hour. We want to pay our direct support staff £10.20 an hour, so as they're getting a good wage and that they're committed. We're asking them to work in some complex, challenging situations at times, so we want the wage to reflect that. We also want a we want a comprehensive management structure around them to support them in their role. We want them to have really good training in their role, and we want them to have clinical leadership in what we do. You're not going to achieve that at £16 an hour. If you want good quality support, it's going to cost more than a race to the cheapest. And we need to develop career pathways and grow good. So some of you know I am chair of the RCN Learning Disability Nursing Forum. I'm a learning disability nurse by background. I'm very passionate about learning disability nursing. Also got a master's in ABA, very proud supporter of board certified behaviour analysts and the work that they do. And I think there's some really strong career pathways there that risk not being celebrated, promoted and followed in the UK as much as they are in other countries. And yeah, we've got some real good career pathways that people could follow, and we just need to develop them further. So a lot of work's going on with Health Education England at the moment in supporting learning disability nursing. We've just started in PBS for our first learning disability nurse apprentice, which is amazing. So we've got one of our support workers is now on a 4-year course, fully paid. They're getting a wage as just they're a support worker. After 4 years, they get their nursing qualification. So we're starting to grow our own talent internally. But we need more of that. We need more career pathways, and it needs to be across both NHS and social care providers, because people with learning disabilities aren't cared for in the NHS anymore, but a lot of the nursing training is focused on the NHS.
Jonathan, it's worth adding there as well that with the nursing apprenticeship, we have the person that's coming through the apprenticeship scheme with us, but they rotate around. So we have other apprentices coming to spend time with PBS4. So I think that's really important for learning disability nurses to come and spend time and really understand what positive behaviour support is and should look like. And so actually by having one apprentice, we're opening that for much. I think, is it 4 we have on rotation throughout the?
There's 8 of them in total.
8.
Yeah, and this is year 1. They'll go on to year 2 next year. I'm hoping to put 2 through next year. Then we'll have all of next year's cohort at the same time as well. So yeah, a lot of fun. And we've advertised one of our PBS clinician roles recently, where we were talking about supporting someone to access the masters through that as well, if necessary, or support people to get their BACB accreditation if they need to. So we've got to look at ways of supporting people to develop their careers and really value our employees. Now, Googled meme that shows how to make it look easy, and this is the one that popped up and tickled me a little bit out there. I think we have a lot of fun in PBS4. It's bloody hard work, but I think a bit like this conference, I'm sure that it's running really smooth and slick for all the participants. Behind the scenes, there's a bit of organised chaos going on, and it's going a little bit bonkers behind the scenes. So it looks really easy, and I think it's really good in some ways, because I think I know I've encouraged lots of my peers and colleagues to do the same, and we've supported other people to do that. There's a nurse entrepreneur in Devon, Lee Cornish, that is setting up his own supported living services, and I've helped him to do that and be part of his journey with that. But I think we need more of that, more small local solutions by local clinical experts to be developed. But yeah, I think there are some other people that have thought, oh well, that looks really easy, we can do that. It looks easy, it's not, but there are some key components to what we do that I can just sort of go over, I guess. So a key cornerstone of what we're doing at PBS4 is the clinical leadership of what we do. So we have a clinical team of 6 now, and we've got the new starters starting, I think. Hopefully 5. Maybe 6. And we're supporting 38 people. So that's, we've got a ratio of clinicians to people we support of greater than 1 in 7. You're not going to find that ratio anywhere else. And it's really important to us that clinical leadership is there in the teams that we do. We can't guarantee it will stay at that. As we grow, it may change, but I think it just really sets the bar for what we're hoping to do. All of our clinicians are trained to the highest competence in behavioural practice. So it's a mix, as I say, of board certified behaviour analysts and learning disability nurses. In addition to that, we've got the ops manager, who is a registered general nurse, and then myself and Anna. So Anna is a psychology graduate with a master's in applied behaviour analysis. I'm a learning disability nurse with a master's in applied behaviour analysis. So we've got that clinical leadership throughout what we do. We have something called clinical ops meetings, where we're just making sure that there's not a divide in some of the larger organisations we've worked in. We found that you've got a clinical team and an operations team, and they can work very much in silo of each other. So we've kind of built in these clinical ops meetings from the start to make sure that everything they do is joined, and that the managers and the clinicians are jointly leading on what's going on in each team. We have assessments and transitions with both management and clinician input. That's really important to us. We need a manager to say, what do I need on a practical level for delivering this support, and a clinician to look at, say, right, what sort of interventions we have to look at getting in place, what sort of assessments do we need to do. Co-produce support plans and risk management plans. And that co-production, it spreads beyond just being co-produced by the managers and clinicians. It's with the teams, it's with the people we support where possible, it's with their families where possible too. We really are trying to work in partnership throughout and be open and transparent in everything we do. We absolutely need to include skill development plans in what we do. Positive behaviour support is far too focused, in my view, on what we're doing to prevent the behaviour, to respond when there's early warning signs of the behaviour, to react to the behaviour when it happens. We've got to meet the function, and to meet the function, we've got to build skill development. Some of it will be specifically about the function that we've identified for the change behaviour. Some of it will just be in other stuff that we've identified would be fun for that person, or would be great for them to develop. I keep getting sent some great videos of a young man we support called Ryan learning PECs, and Sam's presentation earlier on preference assessment and rapport building, just seeing how this sort of task that we've given them of building these PEC skills is actually building that rapport. They're interacting with each other. It's forcing that interaction, but it's turning it into a natural communication and interaction amongst the two and the person we're supporting.
Katie's actually in the talk right now, so she's going to be glowing a little bit hearing that.
Yes. It's a very, very good piece of work.
You have 10 minutes left, Jonathan.
10.
10, yeah.
Okay, right, I better get quick. And yeah, each person has their own monthly incident analysis report. So we're breaking it down, what goes on for each person. We look at episodic severity for each incident. We look at the use of PRM medication, both analgesic and medication for challenging behaviour. And those reports go to the commissioners. They will go to the families if they request them. It gives us that on-the-spot analysis of what's going on.
They also cover as well a quite heavy focus, and it's something we've emphasised a lot more recently as well, is that progress, that data-driven progress towards skills development goals as well. So we're, it's again about taking it away from it being about incident analysis and incident reduction. It's about what skills we're developing as well.
So I believe we've got quite a strong management structure in what we do, and the teams have quite an intensive management for the support they provide. There's a deputy enablement manager and an enablement manager overseeing each of the teams we support. An enablement manager generally oversees 4 to 6 people. And yeah, they're intensely involved with spot checking and supporting what goes on in those teams. We have audits, and our audit process are underpinned by periodic service review. We're constantly striving to make our organisational intelligence easier to see at a glance. So a lot of it is manually done at the minute, which is quite painful for people like Sam. We're trying to make it just pop up by itself, and so we can see at a glance what's going on in each team. But yeah, that's work in development. And partnership working with people we support and their families. A lot of the families, the people we support, will be heavily involved in the recruitment of our teams, and designing the support plans and the risk management plans. I've discussed career pathways a bit, but yeah, we've had quite a lot of training for our enablement assistants. We've got a really comprehensive induction process. There's a 5-day organisational induction, which is usually face-to-face. Current restrictions are obviously affecting that. We've got comprehensive local induction, so you get to know each team, and then we've got things like we've just developed a practice leadership and deputy enablement manager course where we're building skills in those people. Practice leadership is a new area for us. We're doing some work with Roy DeVoe on this at the moment, but the idea is that, you know, too often people who are great at support work, their only way of promotion is into management, into administrative tasks, and we're taking good people who are hands-on away from the hands-on work. So our practice leadership is a way of promotion internally for those people who are good hands-on, keeping them hand-on, but getting some flexibility. So our practice leaders might go into a new team and help develop the culture there, for example. If anyone wants to pop in pop the answers to this in the chat, then they can. Yeah, what we value, being personalised. What I'd say is 90%. This is my gut feeling. There's no real evidence behind this. 90% of change behaviour is stopped by good person-centred approaches. Personalised, bespoke support is what works, and we know that. It does irritate me a little bit when we look at PBS and we're saying PBS is about being person-centered, it's about improving quality of life. Everyone's approach is that it should be about being person-centered, about improving quality of life. You don't need PBS to have a personalised approach and to have good quality of life. But it is a foundation. If we haven't got that approach, we can't do PBS without it. We're about being proactive in what we do. So quite often when you're working with people who are described as challenging, the forefront thought of the support team is, how am I going to manage the risk? How am I going to be ready? And constantly standing in that defensive guard. If a person sees you constantly being defensive, then they're not going to, they're going to do what you expect them to do, I guess. So it's about seeing beyond that and being proactive with people. Everything we do is about enablement and enabling people. People don't need people to fetch their slippers and get them cups of tea. We're there to enable people to live the lives that they want. And being disruptive, that's not about, you know, we want everyone to be rebellious and rioting in our work, but it's just about changing things. We're doing things a bit differently. I often use the analogy of cassettes. I used to listen to cassettes as I was growing up, and to hear the next song, you'd have to press play and fast forward at the same time. And when it pauses, you know, you're at the next one, and you chew up the tape and you got to wind it all in. Then along came Chinese CDs. And when we've got the CD, you can just slip in and just press a button and you're on to the next one. All of a sudden, cassettes become redundant. And what we're trying to do is we're trying to show how social care should be done, so as we can make old forms redundant. That's effectively what it's about. So small steps and slow progress is the key to what we do. It's essential. We've got a learning culture, and it's about being resilient. So for those who haven't got the picture, it's never going to give you up. So I've gone from 90s rock to 80s cheese. I told you it would be highbrow. Challenging, the word challenging has become a bad term, and I don't know why. the word challenging is actually really good. We've actually now got a strapline, challenging expectations. Challenging behaviour says that your behaviour is challenging me, and I love the challenge of seeing someone's challenging behaviour and trying to figure out what that's about. Challenge accepted. I want to take on that challenge. We have many challenging situations that we work in, and challenging families, that's a favourite. When families have had the experiences that other families have had, it's no surprise that they're challenging, and if it was my son or daughter, I would probably be challenging too. So I don't think any of these terms are bad, and I don't think we should avoid them. We're often running up a sand hill, so it feels like it's 2 steps forward and sliding 1 back. And a lot of the slippage is trying to get the cultures right in new teams. We're starting from having nothing and trying to build an infrastructure from thin air. I'm sorry, I'm rushing a bit now. I'm just aware I'm running out of time. But yeah, 2 minutes, crikey. We've got growth and maintain. We've grown quite a bit, so we've got to try and maintain the values in what we do. What worked when we had 50 employees doesn't work now. We've got nearly 250, which is quite scary to think about, really. We've employed nearly right people because they'll do and they'll fit the job, and sometimes that hasn't worked out for us, but sometimes the nearly right ones do, and you get people who've never worked in this area before, and they come with brilliant experience and will bring brilliant values to what they do. Recruitment in general is a nightmare, and developing business supports. Business support's always been an afterthought for me because it's always been about getting the frontline support right from the start. So we've been building the business support afterwards. It's a bit like jumping off a cliff and building your hang glider as you go, but it's been fun. So we're supporting 38 people in 5 counties, nearly 250 people employed. Each person has a dedicated team for them. Rapport we talked about. It's so important to have that close relationship with people, and where people don't have verbal communication, then if you know someone really well, you'll just pick up on those little signs that's going on with them. For a lot of the people we support, we're the most resilient provider they've had. We're the most longest lasting ones. We're still never going to give them up. Strong clinical management team, and PBS is both our practice and our culture. I'm going to skip that one because I've got no time. My usual soapbox is positive doesn't mean good. So I think olives are great, but you might not. So you can't describe olives as not being positive. And quite often in positive behaviour support, we get really confused about this. We think we're supporting positive behaviours. Who are you to say what is positive for me and what's not? Positive means adding. So back to the initial point, really. We're about adding behaviours, not about saying what's good for them. I'll call it a day there. So I've really raced to the end because I didn't think I'd make that much to say about what I had.
Well, I think you've got like 60 seconds. So yeah, impressive. Paddy's turned himself off mute, so I'm going to guess he's going to say something.
Just wanted to play the song. Song.
It's in your head now.
Yeah, it's one of those songs that won't get out of your head.
We need to start putting the song in induction, Jonathan.
Yeah, this is our anthem.
Okay, just before we go, because we've got just one question sort of like typed up. So how does your input help supported living care service providers in minimising and reducing aggressions in young adults? In 60 seconds.
I mean, I can only really talk about the direct support that we provide, because I'd love us to do more consultancy, but we just don't have the headspace for it anymore, which is why we do a lot of joint work with PBS UK. It's about building that rapport, getting the buy-in and commitment. Rapport is central to what we do, and that's the starting block. But I think we can't underestimate the value of having professionals. If you were going to a dentist, or if you were going to a diabetes clinic, you wouldn't accept a diabetes nurse with some internet print off of a diabetes qualification. You wouldn't expect a dentist to have a 2-day training in dentistry. We discriminate against people if we don't give them properly trained professionals.
I think we shout about what we're doing as well. We talk, we share what we're doing. We you know, we're more than welcome to support other people, hear what other people are doing. It's something that we're involved in most of the networks that we're involved around, to share what we're doing and support others. So I think that's key.